May I start by recognizing the presence of the Regional HOHO Administrator, the EGPAF President and CEO, the management and staff, the senior management team present here, our UN family, WHO, UNAIDS, UNICEF, and all UN families that is present here. May I also recognize our healthcare workers from the different facilities and recognize all colleagues from the different programs within the Ministry of Health and recognize the presence of the media in the house. With that, may I introduce myself? I'm Cindy Mate. I'm from the National AIDS Program within the Ministry of Health. I will be directing the program for today. We have not a very long agenda. There are few activities that will be happening here, which will include also some presentations so that we can understand the milestones that have been achieved. I believe we all have received the invitation for us to be here. We've honored that invitation and we are aware why are we here today. But maybe before we go into that, why are we here today, may I request that we start this event with a word of prayer. I will request Dr. Kindanda to take us in a short prayer before we go into our agenda for the day. Thank you.
Very sorry that maybe something very protocolar, but when I pray I want to stand. Not for me, but for the Lord. So it's not protocolar, please forgive me. But I'm covered by the Lord. So let's pray. Heavenly Father, we thank you so much for this time. We thank you so much for this beautiful gathering. We thank you so much for this event. And we thank you for all the people who have come today to share the joy of celebrating 20 years of EGPAF presence in this country. Father, we commit to you all the proceedings. Let this be a day of celebration. Let this be a day where your love is going to be shared, encouragement for job well done, and also as a country taking pride of the achievement that has been achieved. Father, we leave everybody in this place under the covering of your spirit, that we may all, as brothers and sisters, fellowship and celebrate this beautiful time. In the mighty name of Jesus, we pray. Amen.
Thank you, Dr. Kindanda, for committing this event unto the Lord. Now we can safely proceed with our agenda. Just before the prayer was mentioned that we did receive invitation for us to be here, and we are here because we are honoring that invitation. It is an event. We are used to meeting like this when we are discussing our issues within the HIV program. We're discussing data. We are discussing gaps that might be there, but today it's a different gathering. So we are here gathered to commemorate the 20th anniversary or the 20th of EGPAF being in the country, and them pushing their commitment they've made 20 years ago in the country. When they came in, they committed to the Ministry of Health that they are going to improve the lives of Eswatini. They've committed that they are going to reduce the mother-to-child transmission of HIV. And they've committed that they are going to ensure that we have AIDS-free generation in this country. So we are going to hear the milestones as we continue with the presentation. If they've really delivered on that, because we've worked with them, we believe they've done that. But the data, because we believe in data, we are a country that is data-driven. We believe that it is going to tell us if they've really managed to achieve what they committed themselves to, especially after 2 decades in the country. So we really appreciate them and we celebrate them. I wish we can give them a round of applause even before we hear what they've achieved. So we are going to have a few presentations, as I've already mentioned, that will actually give us the picture where we are in terms of the work that they are doing in support of the Ministry of Health. EGPAF is one of our key partners that we have in the country that are contributing in the HIV response. They are working with the HIV program and they are also working with other programs within the Ministry of Health because of the interventions that they are supporting the ministry with. So we'll start with the first presentation. We'll start with the welcoming remarks. We'll start with the presentation that will tell us the journey that they've traveled and the achievements that they've made in the country. I believe that their presenters, I will request that they come up front. So they will be assisted to upload the presentation that is supposed to be made. It will be coming from the Ministry of Health. We have Agebon Sile who will take us through on the presentation. I think I am the first person to celebrate being here today. I'm so excited for being here. Program Director, I think I can say all protocol observed. Thank you for giving me this opportunity just to share the journey that we took together to be here in terms of KMTCT. Well, what I can say is that it has been a long journey. We started in 2002 when we did a pilot on the implementation of prevention of mother-to-child transmission. So when we did that in 3 facilities, which were Mafuteni, Balekane, Beginkosi, and Manzini. Why we started today, remember, we were still advocating to say, can we have this program and all that at that time. And we wanted to find out the acceptability and the feasibility of the program among service providers and the clients. And we drafted the first guidelines. After the pilot experience, of course, we used that to start scaling up. And that is when we met together with EGPAF. I just remember the time when we started, when EGPAF came into the country. We went up and down with the doctor at that time. It was Dr. Ongol. We went up and down, the NGO, making sure, so all those big forms that we filled and everything to ensure that we have EGPAF operating in the country. So we did, we have a history in terms of that. And at that time, we had no M&E systems in place. And therefore, what we had to do with Dr. Ongole at that time, we would sit down, pick all these summary sheets that we had at that time. This time we have more than 40 indicators that we were picking up, but at that time there were a few though, but it was work because as we are scaling up to those 60 facilities, we had to make sure that every month we summarize what. Why so? Because through EGPAF we had got a grant of or a donation from Abbott Laboratories. So each month they needed to have that, the report so that we can get more, and we can scale up. So that is how we have been working vigorously with our partner, EGPAF, and we did a lot of mentoring that time. When we started, we would go, because there were no mentors at that time, but we would go to the facilities and do some mentoring. And I remember one time when we went there, we went to Spofaneni, if I remember. The facility was reluctant to start testing the mothers. They said they don't know how to test, yet we went through a training, and it was a 2-week training, a very extensive training. And we, at that time, we said, okay, maybe let's show you how it's done. Then the issue was, because we are in a hurry to move, who are we going to get to test? Then I said, test me. And then when Dr. Begin was testing me, then we were waiting for the results. There was no pre-counseling, there was nothing. We were just showing them how this is done. And then I became the guinea pig. And that was the longest 20 minutes that I was. If it says positive, well, now I have shown that I'm strong, yet I'm not. But then, after that it came, at that time, things went well. So later on, we continued with scaling up. EGPAF being our electricity partner, we went into all the regions now, and later on we were joined by other implementing partners, including our community partner, where we had M2M, which was supported through UNICEF. Now the roadmap with the key milestones that we had. If you're looking at the coverage at that time in 2002, and amongst those 3 up to 16, we had a 1.5% coverage, which was very low. But because we had partners who were working towards ensuring that scale-up happens, we had to come up with a strategic plan so that we know where we're going and what do we want to achieve. More than anything, it was the issue of scaling up, that we need to go into each and every facility at that point. So when we were scaling up again, there was this experience that we had with Shiselweni region. Now that I'm in Shiselweni region, we had a review meeting, and we found that very few facilities did that. And the answer was that they did not have running water. At that time, it was like we were strict to ensure that the water should be really running, not even from a bucket. So we wanted a running water. So, but then the women are coming in, and then we just ask them, really, what do you want from the women? When you see women in the facility, what do you want them for? Do you want them to have a healthy baby or not? And then they said a healthy baby. Okay, if you don't test them, how do you ensure that the baby is healthy when the prevalence is so high? Then they started saying, then how are we going to do it? Then everyone now was pitching in to say, at our place we're doing this. So we continued with those sharing from there, and we started sharing for all the regions. We had sharing meetings every month. So in terms of scale up, that was in the strategy. Those were the issues that were coming in the strategy. Then we had our PMTCP guidelines, and we went on to an operational plan where we facilitated the establishment of the early infant diagnosis of HIV in the country. We then went on to the third edition of our PMTCP guidelines. We initiated pregnant women with low CD4 count. We moved on again to a national strategy framework for accelerated action, as we are now in the mood to ensure that more women are able to prevent their children from getting any of HIV, any HIV. We went on, as you can see, because things change. As I said in the beginning, it was just nevarapine, but as we continued, we had to adapt to what was coming in from WHO internationally. Then in 2018, now we wanted to end things, because everybody knew that if I go to the facility, I will have to test to ensure that my child doesn't have HIV when then I give birth. So it was all about ending AIDS and syphilis in children. And our coverage at that time now, it was about 83%. Then in 2023, we were able to do a study to find out really, after the time when most children have stopped breastfeeding, then what is the MTCT rate? And we are happy to say we have reached the 1.3. But thank you. However, before that, we as most of you know, we had a challenge in terms, we wanted to, we felt strong in terms of that the targets that we've reached. So we were able to do a pre-assessment for elimination. And that is where we got this recommendation of saying we don't know the final MTCT rate for the country. And we then started this measurement survey. Okay. Well, there was a time when we got to enjoy and being one of the countries who had reached 95. We know that story and we celebrated that 95 target. We are saying 95% of our women, pregnant women were tested, and then 97 of them were put on ART, and then 95% of them were virally suppressed. Then in terms of how far we've gone, or in terms of the final MTCT rate, before we did we used projections in terms of the final MTCT rate and those estimates, but at least, even though we started at 25%, we were gradually going down in terms of, if you look at all the efforts that we put in there, we had so many implementing partners, we had so many trained health providers, the support, the political will was there for us to be able to bring those numbers down. There's a lot that has been done, but eventually, when we did now our own, not an estimate, so we are now, as I've alluded even before, at 1.3%, whereas the WHO target was just below 5%, but we went a little bit further down, which really is exciting for the country. And I must say that we really hope this will be maintained. All the efforts that we are doing will be maintained so that we can, at the end of it all, still celebrate a lesser percentage. Thank you to the partners that are here. I might have forgotten others. We have EGPAF, including USA, we have Elizabeth Glazer, URC, Mothers to Mothers, Georgetown, Global Fund, and our UN, WHO, UNICEF, UNAIDS, UNFPA, and completely for those that have left, but everyone was pitching in terms of this achievement. Thank you so much.
Thank you so much, Bonsila, for that presentation. I don't think that was enough for that applause, especially with the milestone that she has shared here, where as a country we have managed to reduce the MTCT rate to 1.34%. May we still give another round of applause for that. I wish Obejane can do more than because of time, colleagues, may I request that we have another presentation, because you said their mandate is in the prevention of mother-to-child transmission, and may we have another presentation that will take us through, especially with the children that are now testing positive, because she was presenting on the journey on the PMTCT, so now we want to see what is happening with those that are testing positive in terms of being enrolled on treatment. We do have a focal person within the National AIDS Program who is responsible for coordinating this aspect. My request, Nobuhle Mtetwa, to come up front and also make a presentation. I hope she is going to be very short. We are not doing well with time, especially because we delayed starting. Otherwise, we want to appreciate all the results from their contribution in the country.
Thank you very much, Program Director. All protocol observed. Let me take this opportunity to introduce myself. I'm the PIDS focal person at SNAP. I'm Nobuhle Lukele Mthethwa. Party, I have 50 slides, but I'll go through them quickly. Okay, I think we are amongst one of the groups that are lagging behind globally. Our children are still lagging behind, followed by women and men. So I think as a country, we're doing the most to make sure that also our children meet our targets. I think Bonsile has highlighted the issue of PMTCT, but most of our infections are coming from new mothers not receiving ART, some that are dropping ART, and those that are infected during pregnancy. So those are the key areas that we need to strengthen our interventions at. So I think over the years, we have seen that the number of deaths for our children are actually declining, but the number of women that are accessing ART are rising. So hence we are achieving that NTCT rate that Bonsile alluded to. So we are also happy to see that our children that are getting infected are actually declining. We can see we're having less children getting infected because of the effectiveness of PMTCT. Then the number of children 0 to 4 years, that is in the red bar, you can see that they are shrinking. So this is what is expected. So we can see that the children that are actually in blue are the children that were infected in red, and we're actually happy to see them aging out to adulthood. And that is also saying to us our ART or ARVs are really working for them, and they are able to grow into healthy, happy adult people. Then the deaths that we have seen over the years, we can see we used to have 300,000 deaths, but in 2023, we have declined to almost 50,000, and that is an achievement for us in the pediatric HIV cascade. Where we are as a country, we are actually at 95 in the 95 cascade. For our children that know their status, we're actually at 95%. Those that are on ART are 99%, and those that are virally suppressed are 95%, especially on the 0 to 14. For the 15 plus, they are always above 95%. Closing the treatment gap, our ART coverage for our kids, we can see in 2013 we're actually at 43%, but we've actually in this with our interventions and support, they're actually at 90% if you look at 2023 now. So it has been a long journey, but we are actually achieving the desired results through commitment from facility, I think, to even senior management level. We also wanted to talk more about that we had to strengthen linkages for our children to be initiated. With the WHO guidelines, we can see that we are actually following them. They want us to initiate within 7 days, and we can see we're actually at 95% there for the 0 to 14, and within 14 days we're actually at 97%, and within a month we're at 100%. So it means initiation are actually happening at facility level, and we are working in collaboration with linkages. I can see she's smiling over there. And we collaborate. You can see, we will see in my other slides that even if you are in a certain thematic area, you need to be collaborating with the other thematic areas to have success. So this one actually demonstrates that our children are declining in getting infected. Okay, getting children with better treatment options. Our children are on these regimens. Most of our children are on DTG. We've optimized them to DTG. But we have some that are on PIs. We have some on efavirenz. and triple nukes, that is 1%. And then we have those that are unspecified. This one, I wanted us to highlight that we still need to strengthen our CMIS interventions, because there's no way that you can give a regimen that is not specified. Then we have this group of children. We have 52 children that are actually on deadline, that is funded by the New Horizons. Those that in 2013 we actually had one, and we actually applied for that program. In 2024 only 6 joined, but currently all in all there are 52. And we can see that these children, we want to highlight that we've actually decentralized this program to most of the hospitals. Most children can be initiated on deadline in 8 hospitals other than the Vela centers only. So this has actually helped our children. And these children on this program mostly have ran out of options. We had actually one child who is on a clinical trial who had no options at all, but survived because of that trial. And if there was no trial running at that time, we would have lost that child. But in that trial, the child is suppressed and undetected. But that regimen we don't have. All right. All right. Okay, thank you very much. This one, as much as we've achieved the 95 cascade, we wanted to showcase our country. Can you see it somewhere there? You can. You see on the last bar that has the red one. You see the only green bar that's there. You come this side. It is what that has achieved 95 in children. And look at the other countries. They are not even finding us in the 70s. Eh? They are in the 60s, just below the. All because of us achieving. Okay, these are the collaborative activities that I talked about. That for us to have this success that we are talking about, we needed person-centered care, service integration, we needed data use, quality improvement, community involvement. And we've worked with most of the thematic areas in order for us to achieve this success. Our successes, we want to actually acknowledge our MOH leadership through a strong political support, also the foundation from our TWG, PEPFAR, all the UN family, EGPAF, also the rapid adaptation of new guidance, innovation and developmental tools, strong, active pediatric technical team, and we're also a member of the Child Health Forum, clinical systems mentorship targeted at pediatric population, capacity building of healthcare workers in clinical and social care. And we want to actually do more, because as much as we have achieved those, we're still getting new infections. Our infections are not at zero, so we still need to put more interventions. So we're part of the Global Alliance, and we are so focused on closing the gaps. We will improve our data systems, as we have said. We want to focus on caregivers now, formulation, that is ART, optimization, and supply chain. Then we also want to strengthen retention, viral coverage, and suppression. And we have also a thorn on our table, the mental health part, that is our psychological part. We want to work with the psychologists to make sure that we are actually growing a healthy and a happier population, because we know some of our children have issues with disclosure and adherence, and they are a little bit angry, so they need a little bit of attention. And we also want to focus on implementation science to inform and strengthen systems of service delivery. My acknowledgements goes to all of you, and you are all in that list.
Thank you so much, Nobuhle, for the presentation. With all the two presentations, I think as a country, we really deserve to applaud ourselves for the work that we have done so well. I think globally, we've heard so much that Eswatini was the first country to achieve the 95-95-95 UN's target. This is where those 95-95 are coming from. And you've seen from Nobusha's presentation that it's not only the adults, even within the children, we are doing well as a country to make sure that our children, they are on treatment and we are able to retain them and they are virally suppressed. Yes, we do acknowledge the gaps that we have. And she has already shared the way forward. How are we aiming or planning to close up on those gaps? So we really appreciate the support of our technical partner for all the strategic documents that have been mentioned here, the guidelines that have been mentioned here. And I think Bonsile has really shared the journey. And if you remember very well from that slide, that road was very long. It was winding from a first slide to the second slide. It tells you that it really fits into the 2 decades. And we really, maybe we are supposed to be where we are, where we said we are at 1.3% for the MTCT, which is something that we really need to celebrate in this room. Most countries, they are still struggling to really reduce that rate. But as a country, we really tap ourselves on the shoulder for the work well done. With that, I wish we can celebrate that. If we can have our Lutango to come here and help us to celebrate. I think the ululating that I heard initially, it was not enough. They have to come here, and we celebrate as a country. So let's welcome them. Thank you so much, the wellness team. We really appreciate in the Eswatini myself. We're nothing upon having been there enough. Otherwise, thank you so much to the wellness team. We really appreciate that piece. They've been saying Palala, really it's about celebrating. So we are in that mood of celebrating the good work that has been done, the contribution that EGPAF has done in the HIV response. We know it's not only the HIV response that has benefited from their presence in the country. So I wish we can also take some time, because we've been here. Some of us were there in 2003. I remember I was the trainer for the PMTC program. So even the facility that I was working in, it was one of the government facilities that initiated the PMTCT at that time. We're amongst the 16. So I really wish I can give this opportunity to some of us who have been part of this journey to say something per table. I will allow each table to share, just to share a short experience on this case. Where we can't be at 1.3% and you did not contribute a thing. So may I give you the may I start with that table there? My ushers, just have one person sharing per table. There is no table who is not part of PMTCT in the country. They must say something. So we have Christabel who will share her piece in this journey. Thank you, Christabel. Please go ahead.
Good afternoon. Good afternoon. I'm Christabel Mashambi. What I can share is that I was one of the first PMTCT counselors. I started working in 2003. I think I started at RFM, then I moved to Mangayane, where I was then, when I was in Mangayane, I was employed by EGPAF. So it means I'm 20 years old myself. So thank you, that's what I can share.
Anyone with a burning, thank you so much, Christabel. Anyone with a burning experience, with a show of hands? The chief of the chief first.
Thank you, Chair.
Burning experience is the introduction of birth testing. Here in the PMTCT, I met them real time. Introducing blood tests, that's how I know how strong they are.
Another one who can share what is their contribution in these milestones. There is a hand here. Thank you. In that first table there.
Thank you. I'm Kulegan Magogo from Young Heroes. Our first encounter with EGPAF was in the year 2009, when we were addressing issues of adherence among children. And we started the camps. And from the camps, we went on to manage the teen clubs. And those have been going on successfully. Thank you.
May I have the healthcare workers who are in the forefront, who are dealing with the mothers, who are engaging our pregnant mothers, who are also providing services to those kids. May I have a healthcare provider? I'm seeing the faces, the healthcare providers from the facilities. We want to hear their side of the story. Minister Nokulunga.
Oh, choose my kettle.
Choose my kettle.
Let me take the opportunity since the mic is lying on our table. My name is Promise Damini. And today I'm so excited to be here at EGPAF. I recall that when we started our program as psychological care support, we had EGPAF being our forefront. I remember that it was always said that no, patient first, so the healthcare workers were not priority. But EGPAF was the first one who came up. They assisted us to develop guidelines. They assisted us to even run workshops and training to build capacity to our healthcare workers. They even bought us this team building kit that when you invite our office, we use. It's from EGPAF. Thank you.
We have one last one. Okay, colleagues, maybe we can, we'll continue. We just want to recognize the presence of our Honorable Minister, Matebula. So may I request that we are going to cut this activity short now, but we still appreciate to have one or two that can still share their experience. I know there were a few hands there in the table, so may we allow them to continue, and then we'll continue with our agenda.
Good morning, everyone. All protocol observed. Good morning, Honorable Prime Minister. My name is Nondumiso Ngube. What year are we in? 2018, right? I'm the Treatment Optimization Focal Person at SNAP. So what I remember about EGPAF and medicines, I'm a pharmacist. So I remember the Nobutle, she used to sit next to me in the office, and first thing she wouldn't even say good morning, she would say, Yenju. So I remember that very well, and Lydia, Dr. Lydia will be calling and saying, to me. What is happening? So I'm happy to see these achievements because it shows that all of us in our little spaces, we are running to make sure that we achieve 95, 95, 95. Thank you.
One last one. We really appreciate to hear all these. Another one within the table.
Yes,
Thank you.
to acknowledge the Honorable Minister. For me, I'm talking on behalf of the partners, in particular the United Nations. We saw ourselves joining EGPAF at the start by ensuring that the capacity that is required is built around strategy development, the guidelines, even the acceleration plan. I remember at the time I was still a program officer at GNFPA, including the integration of art and family planning as one of the prongs over and above just the clinical care. We want to say congratulations to the Ministry of EGPAF. Thank you.
Thank you so much for those experiences. We can say that everyone has played a role in this. So may I now go back to the agenda, and we have one presentation that is already uploaded. May I request Pilile Episode to come and make this presentation.
Thank you, Program Director. All protocol observed. Good afternoon, everyone. And good afternoon to the Honorable Minister. My name is Kuswe Kumalo. I'm the Associate Director for Public Health Evaluation at EGPAF. My presentation today will aim to provide an overview of the studies that have been conducted over the years, those studies that have been used to generate evidence to inform the programs that we've been implementing. I will also highlight some key findings from some of the major studies that we have conducted. So from this slide, I'm showing studies that we have conducted since 2011 until 2016. In 2011, we conducted a study around barriers to ART initiation among HIV-positive pregnant women. It was important for us to understand issues that were hindering women from utilizing ART. As we know that having women on ART is very important for PMTCT. It actually helps reduce HIV transmission to the children. So we conducted this study so that we understand the barriers and then be able to implement interventions that would encourage the women and later on reduce PMTCT. Then in 2013, we conducted 2 studies. The first one was on exploring behaviors and practices that could increase HIV risk among pregnant and lactating women in the country. Evidence has shown that if women get infected with HIV in pregnancy, they are more likely to transmit HIV to their children. And in Eswatini, we had noticed high seroconversion amongst our pregnant women, and we needed to understand why that was happening. So we conducted this study. And then the other study that we conducted in 2013 was a prospective analysis of retention across the PMTCT cascade. It is important that once we have initiated the women on ART, that they continue taking ART and take it accordingly so that they can reduce the chances of transmitting HIV. And then in the same year, we started another evaluation. This evaluation was focusing on a combination of interventions that were implemented at community level with the aim of accelerating community action so that we can improve demand and uptake of MNCH and also PMTCT services. So this study, we started it in 2013 and was concluded in 2015. But in 2014, we conducted a study to assess community health facility committees. We wanted to see if these committees are actually functioning and what duties they were carrying out, and to see if there's something that can be done to strengthen their leadership so that they can continue working with health facilities and communities to improve health in the country. Then in 2015, we did our most important study in the country to measure the PMTCT program effectiveness. The previous speakers have already alluded about this survey. For this study, we wanted to see HIV-free survival and also the MTCT rate amongst our children. So it's one of the studies for which I'll highlight the findings from this study as I continue with my presentation. Then we also conducted another study which was focusing on knowledge, attitudes and practices among clients and healthcare workers towards provider-initiated HIV testing and counseling. Then in 2015, continuing to 2016, we conducted another study which sought to evaluate the delivery and content of lifelong ART counseling messages provided to newly diagnosed HIV-positive, pregnant and postpartum women in Eswatini. I think the first speaker mentioned the challenges they had with HIV testing. She had to test and receive results without being counseled, that anxiety of waiting for the results. So we also wanted to ensure that our counseling messages are also good and are actually helping to help the women utilize the services that are required for PMTCT. Then in 2016, we had another study which wanted to evaluate the implementation and effect of using point of care early infant diagnosis for HIV. Before then, we were using conventional methods for EID, that is, we had specimen taken and then sent to a central lab and then result taken back to caregivers. But there were challenges, particularly when it comes to turnaround time, that is, caregivers receiving the results of their infants on time, and then those that are testing positive to get initiated on ART. So we then introduced the point of care EID so that we reduce the turnaround time, ensure that children are tested timely, they receive the result timely, and possibly get initiated on ART if they test HIV positive. So this was just early infant diagnosis broadly, but then after we have tested this intervention, we then conducted a study to see that if we continue using POC, EID, to see if we can be able, as a country, to actually conduct bed testing. So we conducted a study to determine the feasibility of bed testing using the point of care EID. And part of that, we also followed up HIV infected children just to see if they are actually surviving, if they test, particularly if they test HIV positive at bed, to see how long they get to survive. And then in 2019, we conducted a study to explore experiences of ANC clients with distributing HIV self-test kit to their male partners. And then in the same year, we also studied another study which sought to actually determine or describe characteristics of children that were failing second line and were in need of third line regimen, and as part of their third line regimen to also take up darunavir. I think the previous speaker also talked about this, that currently we do have children that are on third line and they are doing well using darunavir. And then in 2021, we conducted a knowledge, attitudes and practices survey related to oral PrEP for HIV among pregnant and postnatal women in the country. In the same year, we also started a study to assess the bed outcomes in Eswatini after transitioning to dolutegravir-based treatment. We continued with the study until 2022, and in 2022, we also conducted a study to determine outcomes of children that were on monthly dispensing for ART. In 2023, we looked at PrEP program and client outcomes in all and 7 regions in the country. And this year, we have conducted a study to assess the effectiveness of male-friendly corners on improving utilization of healthcare services among men in the country. Now I'll move on to highlight some of the key results from the studies that have been conducted, starting with the most recent one, which is the assessment of bed outcomes in Eswatini after transitioning to dolutegravir-based treatment. The aim of the study was to determine if there is an association between being on DTG at conception and also the occurrence of neural tube bed defects. So we analyzed data from 45,840 women with their live and stillborn newborns. Overall, we identified 40 cases of neural tube defects, and 0.08% were amongst women that were on DTG. But this rate was similar to that among HIV negative women, which was also 0.08. Given these results, there was no indication that DTG lead to an increased risk of neural tube defects when the women are on DTG. Then the other study is the one that talks to the children that were failing second line and were enrolled on darunavir-based treatment. We wanted to describe who are these children that are failing second line, and also see their outcomes once they are enrolled on Daruna Vet. It is good that the children were being retained in care. They were also virally suppressed once they are enrolled on Daruna Vet, making Daruna Vet an option for third line for children that are failing second line ART. And then the other study is on evaluating the feasibility of bed testing using POC, EID. We collected data among HIV-exposed infants, which were tested at bed using POC. We found that the uptake of POC bed testing was high. That is, a few women were refusing it, but the majority of them were willing to have their children tested for HIV at bed, which is a good thing. And also, most of the infants that were identified HIV positive at bed were initiated on ART, and more than 80% were virally suppressed at 6 months post-ART initiation. Also, this initiative didn't affect the HIV testing for kids at 6 to 8 weeks, which was a good thing. Then the other study is on effect of family-centered model of HIV care, where a family-centered model of care was implemented to try and improve viral suppression and retention amongst HIV infected children. So we wanted to see if this intervention would be effective in terms of improving viral suppression and also retention. It was a prospective cohort of 444 children, but amongst these 379 we were followed up for at least 6 months and more. The results from this study did not show any statistically significant differences between control and the intervention in terms of viral suppression and retention, as much as this outcome was slightly higher in the intervention side, but statistical analysis couldn't find any difference. However, when we look at enrollment data, we found that ART regimen was associated with lack of viral suppression, where the lowest rate of suppression was among children that were on NVP-based ART, and the highest rate was those in the efavirenz-based ART. So this led to the country making sure that they optimize, that children are being initiated on optimized regimen. I think as she was presenting, she showed that we now have a high number of children that are now on DTG and a few on efavirenz and other drugs that are not optimal for their care. And then the other study was also on the implementation of point of care EID, particularly at 6 to 8 weeks. Like I've mentioned before, we wanted to reduce some of the indicators, like issues of turnaround time from specimen collection to disclosing results to the parents, and also initiating those that are HIV positive. From this evaluation, most of the outcomes that we were trying to measure, they did well. That is, we noticed that POC was good for EID at 6 to 8 weeks. And then it also showed that the cost of POC was better compared to using conventional testing. And then this is the study that helped us to measure the effectiveness of the PMTCT program in 2015. What we note here is that the HIV-free survival rate at 18 to 24 months, that is children that were HIV exposed and remained HIV-free at 18 to 24 months, was 95.9%, and the overall MTCT rate was 3.6%. We also noted that older maternal age, delivering at health facility, and receiving ART at ANC was actually protective. That is, it reduces the chances of HIV transmission. And lastly, this is a study that sought to measure the effectiveness of a combination of community interventions whose aim were to improve demand and uptake of MNCH and PMTCT services. Of note here is that these interventions helped to improve attendance of ANC before or at 20 weeks of gestation, and the interventions included community leaders engagement, community days, and having peer classes for men and women. The community leaders intervention had the most impact when it comes to changing social norms. The combination of these interventions were effective in improving certain indicators when it comes to MNCH and PMTCT. In conclusion, the studies have contributed immensely to improve the PMTCT program in the country, and also other HIV interventions targeting children, adolescents, women, and families. And evidence from the different studies have been used to change FDA label around the use of DTG and also the occurrence of neural tube defects. They've also been used to optimize ART regimens for children. They've been used to bring into the country point of care EID, and including introducing bed testing. They've provided guidance on community engagement to improve MNCH and PMTCT services utilization, and also to help retain mother-baby pairs in care. They've been used to provide guidance on providing differentiated service delivery for children and adolescents living with HIV. They've been used to provide job aids for healthcare workers to improve birth defects identification and diagnosis. They've also been used to develop different communication strategies and interpersonal educational and communication materials for different interventions, including PrEP and HIV self-testing. All this work would not have been possible without funding from the different institutions in these slides. And also the successful implementation of the studies, we owe it to the different, to these all different institutions. Thank you very much.
Thank you very much, Pisiwe, for sharing all the results from the different studies. We appreciate as the Minister of Health for the evidence that is helping us to shape up our HIV programming. So with that, may I please allow me to continue with our agenda. At this juncture, may I humbly request the EGPAF Country Director, Dr. Makwindi, to come up front and share still the journey. It's all about the journey, the milestones from the EGPAF point of view. So,
Honorable Minister, or Regional Administrator, the MOH Senior Management, USAID and CDC Country Directors, colleagues, ladies and gentlemen, all protocol observed. For me, it's an honor and a privilege to stand before you as the Country Director for EGPAF. I'm here to walk you through the EGPAF journey, just highlighting the key program achievements. What I'm going to do is just to summarize, what has already been said and how we did it. We also wanted to capture the voice of the recipients of care. In the room, I know mostly we have healthcare workers, the leadership, and everyone else. But what we did, we compiled a video that will give us a summary of the journey. So sit back, relax, and Enjoy.
I am honored to introduce a woman who has been an inspiration to millions, who has been living with HIV, the founder of the Pediatric AIDS Foundation, Elizabeth Glazer. Thank you.
I'm Elizabeth Glazer. While giving birth to my first child, I hemorrhaged and was transfused with 7 pints of blood. 4 years later, I found out that I had been infected with the AIDS virus and had unknowingly passed it to my daughter Ariel through my breast milk and my son Jake in utero.
It was the early 2000s, a time of unimaginable loss and despair. Eswatini was at the epicenter of an unprecedented health crisis. HIV and AIDS had infiltrated every corner of society and had gripped Eswatini in ways no one could have ever predicted. Mothers, fathers, and children were being ravished by a virus that showed no mercy. Entire families were being torn apart, and the fear of death hovered over nearly every household. People dying like flies due to AIDS-related illnesses. This was more evident in the lives of mothers and children. HIV prevalence was estimated at 27%, making Eswatini declared the leading country in the world. The rate of mother-to-child transmission of HIV was alarmingly high, with countless babies born with the virus. The future looked uncertain. Mothers lived in fear, the fear of passing the virus to their children, and the fear that they might never ever see them grow up. Healthcare workers, often overwhelmed, were desperate for support. At that critical moment of confusion and lost hope, the Elizabeth Glazer Pediatric AIDS Foundation arrived in Eswatini with one mission: to end the pediatric HIV and to save lives.
Hello everyone, and welcome. This year marks the 20th anniversary of EGPAF's work in Eswatini, and I'm honored to reflect on our shared journey and the remarkable progress we have made together in the fight against HIV and AIDS. This celebration signifies not only an organizational milestone, but also serves as a testament to the lives we have touched, the children, youths, and families we have supported, and the future we are collectively building.
When EGPAF started supporting the Ministry of Health in Eswatini, that was in 2004, the focus was mainly on prevention of mother-to-child transmission of HIV nationally, that is in all the 4 regions of Eswatini. So pregnant women living with HIV had access to antenatal care services. However, HIV testing was not routinely offered as a part of the package of services. Yet the transmission rate of HIV was around 25% in 2000, as demonstrated by the National PMTCT Impact Measurement Survey. So EGPAF started supporting the Ministry of Health to pilot PMTCT services in 3 facilities, which was Mankayane Government Hospital, RFM Hospital, and KS2, King Sopuza II Public Health Unit.
Hospitals were full. Healthcare workers were overwhelmed and under-resourced. The virus was spreading faster than the country could respond, especially amongst mothers. They came to the clinics with fear in their eyes, knowing their children might be born with the same fate, a life with HIV. They watched in agony as their newborns were diagnosed with HIV. Tiny lives, barely begun, were already facing a lifetime of pain, medication, and uncertainty. Hope seemed like a distant dream, drowned out by the harsh reality that many babies born to mothers living with HIV would soon follow their parents' path. When EGPAF arrived in 2004, there was a glimmer of hope. It brought with them the expertise, resources and dedication that Eswatini so desperately needed. The foundation began its collaboration with the Ministry of Health with a clear goal-driven focus in the prevention of mother-to-child transmission of HIV. With the mother-to-child HIV transmission rate at 18% that year, the focus was clear: to prevent the transmission of HIV from mothers to their children. All concerned parties, government, EGPAF and PEPFAR, realized that prevention of mother-to-child transmission of HIV was to be a priority if we were to rescue the future generation of the tiny kingdom. The vision was clear: to save lives.
When the PMTCT program started in Eswatini, it was a very exciting period, as it promised to be a new strategy that was needed. As a country, we were determined that we do not want any child to die of HIV, and therefore when the PMTCT program was introduced into the entire response to HIV and AIDS, we took it upon ourselves and determined to introduce it into the national program with the aim that we want our children to be born HIV-free.
EGPAF, with support from PEPFAR, upgraded some of the facilities that we were being supported by either renovating the facility or procuring park homes to avail space for provision of PMTC services. A facility on point, it's KS2 Public Health Unit. That facility has been renovated, and many other facilities countrywide or in all the 4 regions.
EGPAF, in collaboration with the Ministry of Health, ensured that pregnant women living with HIV were provided access to antiretroviral therapy and life-saving treatment. These treatments drastically reduced the risk of transmission during pregnancy, childbirth, and breastfeeding. What began as a focused effort in 3 hospitals quickly grew into a nationwide initiative, transforming the lives of thousands of families. Smiles returned on the faces of families as they realized that HIV was not a death sentence, as they held their HIV-free children in their arms again.
We want to express our gratitude to PEPFAR through USAID. They have been a partner in this journey, and the results we celebrate today has been due to that partnership that started 20 years ago and has gone on as we had to keep improving the package, integrating what is currently there, what has been proven to be effective against the transmission of HIV between mother and baby.
Kanza kubalulekile ukuthi mhlawumbe sinceda nayo nemivalo esisho ukuthi udaleke sesisathi isimo sethu lokukhuluma namuhla ngisho ukuthi unasekho.
Despite the remarkable success of the prevention of mother-to-child transmission program, some children are still born with HIV. This can happen for various reasons: treatment failure, lack of adherence to medication, or seroconversion during breastfeeding. For some women, the weight of stigma and discrimination creates barriers to accessing care, leaving them and their children vulnerable.
I started out in March 2006 when I was 1 year. In my family, I'm the only child that takes out. When I was 11 years, I became curious and started asking questions about the pills that I take every day. She told me that I was HIV positive and I got it through breastfeeding. She said she did not know that she was HIV positive. Then we started out treatment.
EGPAF work did not stop at treatment. They recognized that a comprehensive approach was needed to truly transform healthcare for mothers and children, realizing the challenges that were faced by the country at the time, which made it difficult to provide PMTCT services for mothers coming for their antenatal care services. EGPAF, with support from PEPFAR, further partnered with the Ministry of Health to address these challenges. Support infrastructure development, renovating clinics, expanding facilities, and providing essential medical equipment to ensure that services could reach the most remote areas in Eswatini.
So EGPAF worked closely with the Ministry of Health to address these health systems issues in order to ensure PMTCT services were routinized at ANC.
To further strengthen the health system, EGPAF invested heavily in capacity building. Healthcare workers received ongoing training, equipping them with the knowledge and skills to provide high-quality HIV care. Mentorship programs were established to ensure that experienced professionals could guide their peers, building a resilient healthcare workforce capable of saving lives.
As EGPAF, we have strengthened the health system and invested in in-service training, clinical systems mentorship, and infrastructure development through renovation, ensuring that quality care reaches every community.
Through mentorship, EGPAF empowered nurses, doctors, and midwives to be leaders in the fight against HIV. This hands-on support gave healthcare workers the confidence to navigate complex cases, implement new practices, and ensure that mothers and their babies receive the best possible care. None of this progress would have been possible without the support of key donors. PEPFAR through USAID has been a steadfast partner in funding life-saving programs across Eswatini. Their investments have transformed healthcare infrastructure, scaled up HIV services, and enabled access to treatment for the most vulnerable populations.
With the determination to prevent the transmission of HIV from mothers to babies, we recognize that we could not do it alone as a country. We needed to establish strategic partnerships, and our hands were open to partners that were coming in to offer the technical and financial support. So today, the results that we celebrate and see, where we have reduced mother-to-child transmission to very low levels, such that we are targeted for elimination, we can see that it's a result of collaboration, strategic partnership, working together with a shared vision and a shared goal.
Throughout this journey, the dedication of healthcare workers has been remarkable. They have been on the front lines of this battle, tirelessly delivering care, embracing new interventions, and ensuring that mothers and children receive the treatment they needed. Their willingness to adapt and to learn has been crucial to the success of the PMTCT program in Eswatini.
Alongside other key interventions, which were actually game changers towards our fight against mother-to-child transmission, there was the introduction of point-of-care testing technologies, which helped us to deliver results promptly to the women, and also enabling the immediate start or initiation into care for both the mother and also their babies, and also responding urgently to the needs of the client. And with the ongoing mentorship from EGPAF, this ensured that our healthcare workers' skills are enhanced and they are being supported through and through to improve the service delivery, as well as ensuring that there are no clients who are missed throughout the system.
Today, thousands of babies are born HIV-free. One would take this opportunity to thank our dedicated healthcare workers that took it up and ensured that they deliver the service. They would not have done that very well and effectively without the partner support through EGPAF, the technical support, and being able to tap onto the global network that EGPAF has. We've been managing to introduce and deliver quality services.
A lot of children today, they have an HIV negative result after delivery, except for those children whose parents or whose mothers have tested negative during ANC, and they then seroconverted and tested positive maybe during breastfeeding.
Luhlelo le-PMTCT lisite kakhulu livikele nje ukuthi kwehle bantwana labatholakala negciwane. So kule minyaka lengihleli la uma ngikhumbula kahle ngathi kumbe abenze 3 bantwana lesike sabathola as bomake bathathe amaphilisi abo lehle kakhulu lelo zinga.
Today, the results are clear. Thanks to EGPAF's interventions and the collaborative efforts of the Ministry of Health, PEPFAR, USAID, and healthcare workers across the country, the rate of mother-to-child transmission of HIV in Eswatini has dropped from 18% in 2004 to just 1.34% in 2022. Thousands of mothers have given birth to healthy, HIV-negative children, and families have hope for a brighter, healthier future.
Mina kuba negciwane ngilitholile 2008 still solo ngiphila nalo. Ngize ngaba nebantwana lababili. Senginalo legciwane nokutesta kwabo ngeke ngabathatha nabo ngade batisa sibhedlela ngade ubatestisa ngakhanza kwesibona baphilile begciwane ngoba benginalo kwesaba ukuthi ngade babe nalo ngokube nibabo bona. Nalo makwabo yena bevele kude singababona abantu. Ungijabulise naloko bengize babe manana manje ngisaphela futhi sengivekela abantu abami. Sengike ngibone ukuthi bona solo baphila njani. Aphizeke nabathi hayi manje bantwana solo bahlobile.
Over the years, EGPAF's scope of work in Eswatini has expanded to include other areas of interest to address the broader needs of families and communities. While maintaining her focus on ensuring that children are not left behind in the provision of health services, today EGPAF provides comprehensive care and treatment services, ensuring that children and adults living with HIV receive life-saving medication and support. The foundation has also integrated tuberculosis services, recognizing the critical link between HIV and TB, one of the leading causes of death among people living with HIV. In addition, EGPAF has expanded its reach to offer comprehensive HIV prevention services, including education, counseling, and access to preventative treatment like pre-exposure prophylaxis, PEP. As we commemorate 20 years of impact, we celebrate the partnerships, the progress, and the lives saved. Together, we have made a lasting difference in the fight against pediatric HIV. Together, we will continue to work toward a future where no child is born with HIV.
As we look back into the 20 years, celebrating what we have achieved, it is not yet over. We still need to look ahead with the hope and determination that has taken us to this far, and look and ensure that we maintain the gains that we have, and we continue to pursue that no child is born with HIV.
On behalf of Elizabeth Glaser Pediatric AIDS Foundation, I extend my deepest gratitude to the government of Eswatini, PEPFAR, USAID, other donors and partners that we have collaborated with.
We remain committed and leaving no one behind. We just urge everyone to come into the agenda and ensure that Eswatini children are born HIV-free.
Together, we have achieved what once seemed out of reach. Together, we'll continue to save lives, prevent HIV, and build a future free from HIV for all children in Eswatini. Let's continue fighting for an AIDS-free generation.
Together with our healthcare workers, together with our partners, together with partners that will come into the fore, no child should be born with HIV.
I challenge you to make it happen, because all our lives, not just mine, depend on it.
Sorry, it was off. I was saying thank you very much to Dr. Makwindi and also for sharing the video that has highlighted the journey that you have traveled over the 20 years to where we are as a country. We really appreciate the contribution, and we really appreciate also the documentation of the HIV epidemic then and also where we are today. For some of us, it triggers some mixed feelings because we remember how devastating was that period, and also today where we are. We really, you appreciate when you look back and you also compare where we are. And we appreciate that you said when you come in, you had one mission, and that mission was to save lives, and that's what we are seeing today with this MTCT rate that is very low. So with that, may I recognize the presence of the PEFA team that has just come in. We really thank you for also to be part of this event. So may I move on with our agenda to celebrate the results that we've just seen here through this video. May I request our Lutango to come back and give us a piece of
Malala to EGPAF for all the work they've done. Thank you so much for that piece. I think they've done more than they were requested to provide. Anyway, we've enjoyed. I also appreciated Dr. Adler. I saw you tried, but yeah, it was not easy. It was not easy, but you tried. So thank you so much. At this juncture, we'll go into our remarks. We are going to have remarks. The first one will be from the EGPAF President CEO, Chief Leons, and it's going to be virtual. So may I request that we reduce the noise and then we can listen to his remarks. Thank you.
Good morning, Program Director. Can you hear me okay?
Yes, we can hear you.
Oh, wonderful.
Okay.
Good morning to everyone. Good early morning from Washington, D.C. I do have a few remarks that I've prepared because it is an honor to join you this morning on this remarkable occasion. I'm delighted to be here. I'm only sorry I couldn't be there in person. Let me first allow me to greet all of you by recognizing the Honorable Minister of Health, Ndudzi Matsibula, the U.S. Chargé d'Affaires, Caitlin Piper. Certainly, I want to observe all protocols and greetings to colleagues, partners, friends, everyone that we have worked with very hard over the last number of years. My brief comments come from this perspective of having had the privilege of leading EGPAF as CEO for 15 years. Also, as someone who has worked to improve health and welfare outcomes for mothers and children for several decades. What you have achieved as a country, as a government and people of Eswatini in battling HIV and AIDS over the last 20 plus years is historic in public health terms. It is inspiring in human terms. And I'm proud that EGPAF has been an important partner throughout. I don't need to remind anyone of the circumstances in Eswatini 20 years ago and the grave threat from HIV and AIDS. At that time, some spoke of an existential threat to society, a breakdown in the conduct of everyday life, potentially affecting everyone, not just those infected. But that's not what happened. What happened was the kind of call to arms led by His Majesty the King. What happened was the government of Eswatini was an early adopter of policies and strategies aimed at fighting back against HIV and AIDS, as the Honorable Prime Minister said recently in New York at the opening of the UN General Assembly. What happened was the rallying of healthcare workers, doctors, researchers, communities, faith leaders, operational workers, everyone for whom HIV and AIDS was life and norm threatening for the country. What happened was the decision by President Bush and leading members of Congress to provide a level of leadership and support through PEPFAR for a global health response that was and remains unprecedented. What happened was the forming of partnerships like that between USAID, EGPAF, and others with the Ministry of Health. And so today, what do we have? We have dreams that have come true. Eswatini is controlling the epidemic to a degree that only the most incurable optimists 20 years ago could have hoped for. Eswatini has become not the example of a disease upending a country, but the example for the region, for Africa, for the world, of controlling that disease. For me, that makes Eswatini a leader in public health, an exemplar of how to fight HIV and AIDS with its partners. We often hear references to the so-called giants of the continent, Nigeria, South Africa, Kenya. I understand. But for me, Eswatini is the giant of Africa in terms of what has been accomplished in controlling the epidemic. It is an amazing achievement. closing, I have two important caveats. Everyone assembled knows full well that while we have, together with so many partners, won huge battles, and we have won a kind of peace from the menace of HIV and AIDS as it was lived 10 and 20 years ago, I think we also know that we have to be reminded the war is not yet won. Not as long as there is no cure nor a vaccine against HIV. The war is not won as long as children lag behind adults in testing, treatment, care, and viral suppression. We have big challenges still. They include sustaining this peace by keeping and expanding services, and to absolutely include the affected children of Eswatini. Don't make them wait any longer, or we can't ask them to be resilient. They're children, after all. They and their mothers should be first, not last, to benefit from all the efforts to control and sustain that control of the epidemic. The dreams of President Bush and everyone who has ever been a part of PEPFAR can be seen in Eswatini. The fruits of your and our combined efforts are fresh and visible in Eswatini. Elizabeth Blazer herself did not have time enough on earth to dare to dream of the contributions made in her name by EGPAF. But your dream was her dream for her only child when she was battling HIV and AIDS. On a recent visit to Eswatini, I met with this wonderful couple, husband and wife, both living with HIV. They introduced their son, now aged 17, as living, as they phrased it, in peace, free of the virus because of their actions, the services provided by government, because of the partnership with PEPFAR and others, and because of support from EGPAF's team in Eswatini working hand in hand with USAID, the Ministry of Health, and other partners. So of course, let us embrace and celebrate a profound sense of peace in Eswatini. But let us pledge today that we will not take it for granted, that everything possible must be done to sustain this precious peace, to include everyone infected and affected, to include the children and their mothers in this peace, and to make the changes in strategies and funding essential to keeping the peace until we have truly, globally, won the war against HIV and AIDS. I thank you all. I salute you all. I celebrate you from a remove with all of you. It's an honor for me to have been invited to speak with you. Thank you.
Thank you very much, Leon, for those remarks. We really appreciate for joining virtually. We would have loved to be, for you to be part of us as we celebrate this big event today. And we also appreciate the encouraging words that you've shared with us. We affirm that we are going to remain the giant of not only Africa, he said globally. So we'll remain the giant even globally. Because we have that responsibility of maintaining the gains and closing the gap so that we remain at that status that he has just shared with us. With that, may I humbly request the United States Church Affairs, Kathleen Piper, to also make remarks. So may we give her a round of applause.
Good afternoon. It's an honor for me to be here with all of you today. It's an honor for me to be following Mr. Chip Lyons after his inspirational words to us. And I want to thank the program director for not scheduling me to speak after that amazing performance of the women singers and dancers. So before I begin my remarks, I just want to greet and thank a couple of you in particular. Program Director, again, thank you so much. Hohoho Regional Administrator, Princess Tanzile, princes and princesses here today, Honorable Minister of Health, Minister Matsibula, EGPAF President and CEO, Mr. Chip Lyons, and the entire incredible EGPAF team here today, senior officials in the Ministry of Health, PEPFAR colleagues, and our incredible PEPFAR implementing partners, healthcare workers, distinguished guests, members of the media, ladies and gentlemen. Once again, I am so honored to be here to mark this occasion where we really have an opportunity to reflect on the collaboration between the Elizabeth Glaser Pediatric AIDS Foundation and the government of the Kingdom of Eswatini over the last 20 years. True to its American founder, Elizabeth Glaser, who lost her daughter and eventually her own life to AIDS, EGPAF has been a tireless advocate for children affected by HIV. Imagine if Elizabeth could witness the progress made in the fight she championed on behalf of children. Today, we find hope in having contributed to saving 25 million lives globally, including ensuring that 5.5 million children are born HIV-free. As we all know, and as Mr. Chip Lyons alluded to, in Eswatini the situation was as acute as it was anywhere in the world. When the Prevention of Mother-to-Child Transmission, or PMTCT, program began in 2003, the rate of mother-to-child transmission was devastatingly high at 18%. HIV was a threat to an entire generation of children. But through your hard work and through your unwavering commitment, mother-to-child transmission of HIV in Eswatini has now fallen to 1.34%. And while we know that Elizabeth Glaser would surely implore us, and really implore us, to keep driving the rate of new HIV infections among children all the way to 0, I think she would also join us in celebrating this tremendous accomplishment. We congratulate the government of the Kingdom of Eswatini, our PEPFAR implementing partners, and especially healthcare workers for their tireless efforts in prioritizing children in the HIV response. Now, as we know, the HIV response in Eswatini still faces several challenges, including gaps in treatment for children and alarmingly high rates of new infections among adolescents and young women. The United States government, through PEPFAR, will continue supporting interventions to ensure high HIV treatment and coverage in innovative HIV prevention initiatives, such as oral and injectable pre-exposure prophylaxis, known as PrEP. Our support for the PrEP program will also focus on reducing new infections among HIV-negative pregnant and breastfeeding mothers, which in turn reduces new infections in children. Program Director, the children served the United States partnership with the Kingdom of Eswatini are a tremendous source of pride for the U.S. Embassy and for the people of the United States. As we commemorate 20 years of EGPAF's impact in Eswatini, let us celebrate progress while also reaffirming our commitment to protecting children and young people from HIV. Thank you so much.
Thank you so much, Kathleen, for those words and for continuing to remind us that as much as we have made so much significant progress course, in the HIV epidemic, we still have gaps that we need to continue to close within the subpopulation. Thank you so much for that. At this juncture, may I request the person who's supposed to give us poem to come up front and provide that. I'm trying to look for the person who might be moving around.
Good afternoon, ladies and gentlemen. All protocol is humbly observed. I am Siboni Sile. I will be performing today a poem based on the reason we're here today, to celebrate and commemorate 20 years of successfully fighting pediatric AIDS in the Kingdom of Eswatini. Allow me to take you with me on a journey of the past 20 years through the eyes of a pediatric HIV survivor living free from HIV. HIV/AIDS, the perpetrator of shattered dreams, destroyer of futures, and facilitator of broken lives. How you dreamt to be a guest in me, but sadly, to your detriment, I was saved and set free by PMTCT. Glad you would be to flow through my veins like you did with those of my mother, like you did when I was conceived. Rejoiced, didn't you, when I was conceived? Fresh new blood, innocent soul, you presumed, indeed presumed, you would make your breeding ground. Mother, she loved me. She gave me a chance through PMTCT. Now, who is this PMTCT of whom I boast? A woman in the land of America had a dream to see lives like mine live, a dream brought to life by another who cares. USAID PEPFAR. Seeing that I was far, USAID placed me in the hands of another mother, EGPAF, named after my mother who loved me from beyond the seas. Standing tall in her stride is the Elizabeth Glaser Pediatric AIDS Foundation to support the efforts of my local mother, the Ministry of Health. Normal is the life I lead today, free from ARVs and countless medications. I am living my life without limitations. Avoiding to ever cross roads with you is a guarantee, for I have been given a chance through PMTCT. Another chance I have been given, and grab it with both hands I shall. I shall no longer cry HIV and AIDS, grovel and beg for your mercy on mankind. For I have been given a chance through PMTCT. Future generations have been given another chance. Prevention of mother-to-child transmission of HIV. PMTCT. Through PMTCT, we have opened many a door, and through those doors, Eswatini shall rise to fall no more. HIV. Happy 20th anniversary to the Pediatric AIDS Foundation in Eswatini. Thank you.
Thank you so much for that, and thank you for even you relating. We really needed that. So that's what we are supposed to go out with as we leave this place. We are almost at the end of our agenda. For those that might be worried, we are almost there. So at this juncture is my singular honor to invite our Director of Health Services to come up front and introduce our Honorable Minister of Health.
Thank you, Program Director. As introduced, Dr. Okello, the Director of Health Services, and my role, I'm split here. My role really is to introduce the Honorable Minister. But the Honorable Minister is looking at me, and in one of the meetings before, he said, yes, because there's a lot to say, honestly, having been a member of the team. This big team that is here, that has responded to HIV and AIDS in this country since 2004. We all worked together very well, integrated services, pushed out, rolled out services, but let me stop there for now. I would like to introduce Honorable Minister of Health, who is Mr. Mduduzi Matsebula. He is a member of Parliament for Inkundla, Yasas around Babani here, and in the way that he works, he's really a man of the people, being elected by the people. So in our work since he came, really he's reminding us of the needs of the people on the ground, which maybe in previous years we haven't been very much privy in getting that outlook. So thank you, Honorable Minister. We'd like to appreciate your presence here, and I would like to ask you to come forward to give us your remarks, and may we welcome the Honorable Minister with a round of applause. Thank you. Yes, we can stand up if you wish.
Thank you. Program Director, our Regional Administrator, Princess Tsanzile, United States Ambassador to Eswatini, Mage K.U. Piper, EGPAF President and CEO, Chief Lions, who joined online, Senior Management of the Ministry of Health, EGPAF Country Director, Management and Staff, leadership of the different implementing partner organizations. I can see USAID Country Director, CDC Country Director, WHO Country Director, PEPFAR, the CEOs of the different state-owned enterprises. Lutsango, please put your hands together for Lutsango. The media, ladies and gentlemen, good afternoon. It is a privilege and honor to be present on this occasion today to commemorate 20 years of remarkable progress, dedication and hope in the shared fight against pediatric HIV, and the remarkable collaboration in the improvement of health services in the Kingdom of Eswatini. I am particularly proud of the profound impact the Elizabeth Glaser Pediatric AIDS Foundation, EGPAF, with support from PEPFAR, has made in Eswatini. Through this support, our children have the future they deserve, a future free from HIV. Program Director, this is a very special event for all of us, giving us an opportunity to reflect on the mileage we have covered in ensuring that our children are free from HIV. Through provision of life-saving antiretroviral treatment during pregnancy, this is a moment for us to pat ourselves on the back and appreciate the role played by each one of us, especially our healthcare workers, who were in the front line from the first day this intervention was introduced. Please put your hands together for the health officials. Distinguished guests, I recall very well the dire situation that the country was facing in the early years of the HIV pandemic, especially around the year 2000. Pregnant and lactating mothers and their children were dying of AIDS-related disease. According to the National PMTCT Impact Survey, the transmission rate was at 25% in 2003. The HIV situation in Eswatini was alarming, particularly among our children. Many babies were born with the virus and their future seemed uncertain. EGPAF's mission of eradicating pediatric HIV globally saw Eswatini being part of the countries to implement prevention of mother-to-child transmission of HIV, PMTCT, in 2004. The Minister of Health, with support from PEPFAR through the EGPAF, introduced life-saving interventions that reduced the mother-to-child transmission rate from 18% in 2004 to just 1.3% by 2022. This achievement was once unimaginable, and today it stands as a testament to the power of partnerships, determination, and the collective efforts of the healthcare workers and communities alike. I would also like to extend my sincere appreciation to His Majesty, King Mswati III, whose vision of an AIDS-free generation has guided our efforts in the fight against HIV. This unwavering commitment has ensured that we continue to make progress towards ending HIV in Eswatini. May I also take the moment to recognize and honor the contribution and support of Ingosigati Magelampiza in this important area of mother and child health. Her advocacy, work through the campaign on accelerated reduction of maternal mortality in Eswatini assisted the country to strengthen our efforts, resulting in a decrease in loss of life for both mother and child. Please put your hands together for Magelambi. While we celebrate the achievements of the past 20 years, I stand before you to urge us all not to be complacent. We must strengthen our efforts in addressing HIV, particularly among adolescent girls and young women who remain disproportionately affected by the epidemic. They are the future of our nation, and we cannot allow them to be infected with HIV. The time is now to double our efforts and close every gap that might result in our young generation getting infected with HIV. We do not want to see the repeat of the past, and we want Eswatini to take the lead and be declared an AIDS-free nation by the year 2030. I'm happy that Nondumiso was looking at me. I call upon all of us, government, partners, healthcare workers, and communities to ensure that no child in Eswatini is born with HIV, and that we reach our goal of the total elimination of vertical transmission of HIV. This is not just a goal, but a moral responsibility we all share. With the continued support and collaboration, I believe we can achieve this vision. To the mothers and children living with HIV, I encourage you to adhere to your treatment. Adherence is essential in ensuring health and well-being of both mother and child. When mothers adhere to antiretroviral therapy, they significantly reduce the risk of transmitting HIV to their children during pregnancy and breastfeeding. For children diagnosed with HIV, early enrollment in treatment can save lives, giving them the chance to lead healthy and productive lives. Program Director, His Majesty's Government remains deeply committed to sustaining epidemic control and maintaining the achievements we have made under the 95-95 UN AIDS targets. We are focused on ensuring that everyone knows his or her HIV status, and those diagnosed with HIV receive sustained antiretroviral therapy, and those on treatment achieve viral suppression. Our progress is significant, but we must remain vigilant in maintaining and exceeding these targets. In closing, let us remember that this is a journey of hope, resilience, and action. The fight against HIV is far from over, but together we have the power to make a difference. Let us continue to work hand in hand, ensuring that our children are born HIV free, our mothers stay healthy, and our communities thrive. With continued partnership and commitment, I am confident that Eswatini will not only achieve an AIDS-free generation, but will also serve as a beacon of hope for others across the continent. Once again, let me congratulate Elizabeth Glazer Pediatric AIDS Foundation for the 20 years of a successful partnership with the Ministry of Health, Eswatini. May God bless us all as we continue this vital work of ending AIDS in Eswatini. Siyabonga.
At this moment, Honorable Minister is receiving a gift. Then we'll request the table which is seated with the Honorable Minister to come forward for a photo session after the gift session. May we request the high table that is seated with Honorable Minister to come forward. They will be followed by the staff of EGPAF. May they get ready? The staff from EGPAF. Thank you very much. With a round of applause, may we allow the first Honourable Minister to remain. Honourable Minister, please remain. Thank you. The Ambassador, Church Affairs, thank you. May now we request EGPAF staff, senior management, I think we are full, we are all over the country. Please be represented by your senior management. not that you are not important. We knew Dr. Lydia. Thank you. Honourable Minister, please remain. And touch the affairs, please. Yes, because and now we'll request program managers who are here. We know our programs. There is ENAP, which is SNAP. There is SRH, current and former. And program managers, please. Because in this journey we are all together. Program managers, TB, labs, we know you all played a very important role in the services that resulted in these achievements. Try to come together, okay? Okay, these are the program managers who all work together, as I already mentioned, integrated approach of services from lab, management, I don't see pharmacists, but we have lab, we have different. Yes, because without the pharmacy lab and the clinicians, we wouldn't have achieved. Finally, we will ask the representative of the regions, because our health facilities are within RHMTs. So please, may I request regions, whether it's Metron, whether it is those who are here. Okay, if they are not available. Metrons, yes, PHA, yes, of course. Budonga, are you there? Lubombo, there's Boho, Manzini, Lubombo, Shiselweni. Other side. So, because our implementation is really, this is the team that oversees the implementation on the ground, down to the primary healthcare level. We also would like to make sure they are recognized for their efforts in ensuring that facilities are functioning on the ground. A round of applause. Lastly, country directors, please. ICAP, yes, you know yourself, GU, UNFPA, you can come back, ED, Nature. I think you know yourselves, AHF. At least I am aware of most of you. And see all this. Please try to line yourself up. Maybe Honorable Minister can come forward. Yes, thank you. Yes, please. Give me 3. There's a suggestion to have some chairs for some of those in front. Maybe the Honorable Minister and just maybe 4 of you. Thank you so much, Director. Thank you so much, Honorable Minister. We have come to the end of this event. I would like to thank everyone who has been part of this remarkable event. I think when I started, I thanked you for coming. I still thank you for being part and also for making this event delightful, and you gave it the level that it deserves. We really appreciate that. May I request that we are going to be served with refreshments. They are served just outside. So I will request that we allow the high table to go outside and then they will come back. We are all going to have our food inside here. So we'll just go outside, we allow them and then we can follow them. We dish and then we come back and have our food aside. So with that, may I request that we close with a word of prayer. I think Dr. Kinande is still around. May you please take us back to the Lord and thank the Lord for being with us throughout this event. Thank you so much.
May we stand. At least I have supporters now. Style of standing. Heavenly Father, we are here as your children, thanking you so much for this moment. This was beautiful and is still beautiful. We have enjoyed being together, celebrating the achievement that as a country, as a team, you have allowed us to achieve. It's true the journey is still before us. There's more to be done. And this is where we come and commit ourselves as a country in your hand. Bless our SMT, our MOH SMT. Give them the strength, the wisdom to lead this country in this fight for an HIV-free generation. Bless all the workers, healthcare workers in the facility. Bless all the partners that are contributing bless all the funders that are committing their resources so that we see light in this struggle. We recommend ourselves to you even as well about to partake from the food that you have made available for us. May whatever we are going to eat brings strength and health in our body. And we have prayed in the mighty name of Jesus, and we all say amen.